We're glad to welcome back to the morning show from Henry Ford Jackson Hospital, Vice President of Population Health, Dr. Courtland Keteyian. Good morning.
Morning.
Welcome back.
Thank you.
Here we are halfway through the summer, and a lot of people predicted that once people got outside and we were in fresh air and we were on top of one another, we'd start to see some reduction in cases, but it looks like in Jackson we're pretty much just staying level. We're not going up, we're not going down.
I think that's true. I think that even though we've been outside, there's been a lot of gathering happening with the holidays, and we've seen cases stay relatively level. We got a little bit of a bump in June, kind of going into the 4th, and then we haven't really seen it trickle off. I think the thing that's important to remember is when the cases people look for that are reported, like the county health department tracks those cases, and they can see cases that are basically done, the PCR tests that are done, places like the hospital, some of the pharmacies, urgent cares in town do PCRs. Those get reported to the state, but all those rapid tests people do, nobody knows about those. So we have a lot more activity going on right now that we don't really know about. And it's really hard to estimate how much that really is. But when we test people at our drive-through testing site at the hospital, like 40% of the tests are positive.
Really?
Yeah, and a lot of what happens is people will take a rapid test and they might want to get a confirmation or something like that, but that's really high, and so we know that there's still a lot of activity out there, even if we're not seeing it in the health department numbers.
So if you think you have it, odds are 1 out of 2 that you do have it.
Yeah, I think that for people that have any upper respiratory symptoms at all, it's really COVID until proven otherwise, right? And I see this all the time where I think people will be like, oh, I have this little thing and it'll go away, it'll be fine. It's like, it's not. I mean, you really got to get tested. You can't distinguish it based on symptoms. I mean, even some doctors I think make that mistake is, it's like, well, we'd have to test everybody all the time. And it's like, well, yeah, that's kind of what you have to do. You have to test everybody all the time because you really just don't know. You don't know unless you do the test. You just don't know.
Now, those home tests, though, how accurate are they?
It depends. So if somebody does not have symptoms, and they use this way all the time, it's like, well, we're going to take a test and then go hang out with our family because the tests are negative, right? Or go do something together. In that environment, the rapid test is probably about 30% sensitive. So that means you're missing 70% of cases. So it's pretty useless for that type of indication. If somebody's very symptomatic, so fatigue and especially the upper respiratory stuff, a runny nose and cough and congestion, they're really good in that sense because you're picking up. There's enough viral load, the test is going to identify it, right? So when somebody's symptomatic, they're pretty good. But there's kind of this spectrum in between where, unless you have those specific types of symptoms, they can miss it. So you have to be really careful how those tests get interpreted because they get misinterpreted all the time.
Plus, our attitudes really have changed. When you look back at the early days of the pandemic, if someone was positive, they were quarantined. They went to a hotel for 2 weeks.
Right.
People slid their food under the door.
Right.
We're not that way anymore.
No, we're not. And I think there's good reason that we don't have to be anymore. I mean, I think that now people are vaccinated, and when you're vaccinated, your risk of an adverse outcome is significantly reduced. And we have medications available that can mitigate those adverse outcomes. So there's definitely steps we can take now that we just didn't have available before, but it was much scarier then when it's like, well, if somebody gets it, you're like, we don't have a lot of tools in the tool belt. But that still doesn't mean that we should be cavalier about it because, I mean, we have, last count I saw, I think this was yesterday's data, there's been 579 deaths in Jackson County since the beginning. And a few weeks ago that was 550, right? So every week a handful of people are still dying. So we're not at the point. There was a point in December, January where 2 people died every single day on average. And now it's, a few people a week. But still in Jackson County, right, a few people die of COVID every week. So that there's not a lot of other things happening where that's the case. And the hospital continuously has somewhere between 20 and 30 people with COVID all the time. And that's 10% of our beds. So we're using 10% of the hospital beds all the time, like baseline, just to care for COVID patients. And some percentage of those are not surviving. And that's what's happening. So I think people have to really be, that's what you're really aware of, is even if you maybe don't feel that sick, right? And you say, well, it's just a little thing, I'm gonna go out, and you can make somebody else sick. And that can be life-ending for that person, right? It can be very, very consequential. So that's where I think we really still need to be considerate of other folks, and avail ourselves of the tools we have, like the vaccines.
So we have, with those number of deaths, it's mind-boggling, really. No, 600 people have died in Jackson County from the pandemic, and there are those that say that, well, maybe these people would have died anyway, or we lose that many people with the flu, but that's not the case.
No, I mean, statistically, that's just, those things are not true. And I've heard people refer to this as the flu, but I mean, it's orders of magnitude easier to transmit than the flu. I mean, literally exponentially more transmissible than the flu. I mean, on average, the flu virus will infect, 1 to 2 additional people from one person that's sick. This Omicron variant will infect more than 10 people on average from one person that's sick. I mean, it's so easy to spread. So flu doesn't spread like that, and flu doesn't kill people like this. There aren't 1 to 2 people dying a week from the flu in a normal flu. It just doesn't happen. I mean, this is far easier to transmit, and it's much more severe than influenza. So it's just not a good comparison, and it's going to continue to circulate. So I don't think we're going to see this go away. We're going to continue to see the virus change, and then we'll get new variants, and then we'll have to deal with those. And that is going to be that is new normal, right? Like this is normal. It will be like this.
Is everybody going to get COVID?
It seems that way. It seems pretty hard to avoid. I mean, I think it all depends on behavior, right? I mean, if you're somebody that doesn't go out a lot and is sort of very careful who you interact with and wear masks regularly, it can certainly be avoided. Which is good, because I think there's a lot of people that really should avoid it, because it could be really bad for them.
Should we still be wearing masks?
I think in certain settings, it's really something we should consider doing. So in my clinic every day, I have a mask on the whole time. My patients wear masks, I wear masks, and that's to protect me, but it's also to protect the patients in the clinic, right? People come in that are sick, and they should be protected. In the hospital, we all wear masks. And again, there's people there that need to be protected. Even when I do the sort of administrative part of my job, if I've got a whole bunch of team members and we're all going to sit in the same conference room, we're going to put masks on, because that makes sense. Because if there's one person that has COVID and they could be in that asymptomatic phase for the few days before they get symptoms, not knowing that they're transmitting to other people, which is when most transmission happens, by the way. It happens before people know they're sick. So people think that they can get sick and just be like, well, I'm sick, I'm going to get away from other folks. It's the 1 to 2 days before you got sick that you infected the most people.
Really?
Yeah, so we just prophylactically, right? If I'm going to sit in a room with 10 other people, we're going to put masks on. There's no harm in doing that, right? And if the next day somebody says, I don't feel very good, that's okay, because we were all in the room with a mask on, and we mitigated that exposure. And so we can be smart like that. We don't have to. It doesn't have to be all mask or no mask. You can sort of, where's the settings that make the most sense? And if I'm in a room where the air doesn't move with a lot of people, I'm going to put a mask on. It's good practice.
A concert.
Yeah, exactly. Yeah, and there's concert venues that still they require masking, right? To say everybody's got to have a mask on in here. That totally makes sense. Airplanes to me is crazy. Getting on an airplane without a mask on, that's nuts. And I know that's the policy now, that people can do that optionally, but that is an enclosed space, and they filter the air, and there's HEPA filters and all that kind of stuff, but you're in really close proximity to a lot of people.
Yeah, you're on top of each other.
Yeah, I mean, so what's I'm never going to ride a plane on without a mask on here, if even a code goes away, right? Because even think before you get on a plane, people get sick all the time with travel, right? And somebody coughs, you're just really close to them. So what's the harm? Put a mask on. You don't get sick on the plane. It's an easy thing to do, and you're better off for it.
Yeah, a couple hours.
Yeah, it's a couple hours in a mask. It's not a big deal.
So the new variant BA.5, the dominant variant, it's more easily transmissible than the previous variants. Does it make you sicker?
So that is something that is being, I think, very actively looked at. In other countries that are a little bit ahead of us with this particular variant, they have seen some uptick in their hospitalization rates. And that's the thing that I think people really worry about, because what's happened is, as each of these, as we've gone from alpha to beta to delta to now Omicron, and now we're on subvariants of Omicron, right? We were at BA2, BA 2.1.2, and now we're at BA4, BA5. Each of these gets easier and easier to spread. And the concern is, if you have one that's easier to spread, but then also causes that deeper lung infection like the Delta variant. The Delta variant was really the most severe so far in terms of the disease that it caused. So that's kind of the worst case scenario. And I think the jury's still out a little bit on how severe the BA5 variant is. It's much more transmissible. So what happens is people will ask, what variant did I have, right? It doesn't really matter. I mean, if you have COVID, you have COVID, the treatments are the same. But what happens is the state actually samples tests that are taken from different parts of the state. And so they kind of take a group from a certain location, and they do the sequencing on that sample and see what it is. And then they can see, like, okay, statistically, what percentage of the cases are now the different subtypes. And so they can say, now it's 80% of these are BA4 and 5, which is the case. And a month ago, middle of June, it was like I think like 10 to 20% of cases were 4 and 5. So it has overtaken the original BA2 variants of Omicron very rapidly. So that does have people concerned because of how fast that shifted. And so now you have this dominant strain that's very transmissible. And the immunity that people have gotten either from previous infection or vaccine seems to be less significant when sort of faced against the BA4 and 5. So protection people have sort of naturally from vaccine is just not as good, which is why we're hoping for these new vaccines to be coming out in the fall that are more specifically targeted against the new variants.
Yeah, I've heard there are people that have COVID, they recover, a month later they get it again.
Yeah, and that's probably a different variant. And those folks, some of those folks may have different, sort of immunocompromising conditions that affect their immune response, but that's definitely happening now, where people are having had Omicron and then they're getting a subvariant of Omicron, the BA4 or 5, 30 or 60 days later. So the common wisdom was that you had basically like kind of a 90-day, safe zone or whatever after you've had it, where you have really high circulating antibody levels and you're probably very safe. But now we're not really seeing that is true anymore.
What about the vaccine? They're working on updating the vaccine to reflect the changes in the virus. What is the timeline? So people that have the first series last year, then got a booster. Mm-hmm. Should they wait to get their next booster?
That's a great question. And actually, so there's actually two parts of this. So I think, because I want to address the adults and then also kids. So the youngest age group of kids just had, were just authorized to get vaccine, period, right? Not even just boosters.
6 months.
The 6 months old to 4 years, so anything less than 5 years old. And the uptake in that group's been very low. That's still really important to get those kids in for their first shots now. So there's no reason to wait in that group. In pediatricians' offices in town and health department have vaccine available for that group of kids. So that's one thing that's really important to emphasize. There's been there's different numbers, but I think it's somewhere around 1,500 pediatric deaths throughout the course of the pandemic. So getting that group vaccinated is still really important. Now for the booster question, so basically if you're over 50, the recommendation is to now get over 50, or if you have other immunocompromising conditions, you can get a second booster basically. So this would be the fourth dose of an mRNA vaccine. And I would highly encourage people to still get that rather than waiting Because what will happen is, if you get that booster, you're not going to have to you're still going to be able to get the other one. It's not like it's going to prevent you from getting the new one that's targeted at the variants. In the new vaccines are both the Pfizer, so Pfizer and Moderna are both developing them. They're both in phase 3 trials right now. Moderna actually just released some data yesterday to show there was some very positive protection from their version of this. And these are what's called bivalent vaccines. So they're actually including sort of content that will protect against more than one strain. So they're basically protecting against the original strain, the wild type, and now against these BA4 and 5 Omicron, or an Omicron, sort of family of variants. So it's both, is what both Pfizer and Moderna is a strategy they've been using. And so those look like they'll be available in probably early October, is what the expectation is. But I mean, it's July, so if I were eligible for another booster, I would definitely get it. And then when that comes out, it comes out. There's nothing to say that's going to be ready in October either, right? So what if that's January, and now you've waited 6 more months? You really, really should get the other vaccine if you're eligible for it now.
How soon after your first booster should you get your second booster?
It's a 4-month interval, is what the recommendation is. Yeah. So after the primary series, it's basically 6 months. It's 5 or 6 months, and then depending on how you count the first or the second dose that you got, and then you would get the subsequent booster would be 4 months after your first booster. And then any time after that, I mean, if it's been 6 months or 8 months, you still get it. I mean, there's no reason not to get it. I mean, I had my first booster last November because that was as early as I could get it, and I'm not in the over 50 age group, so I'm not eligible to get the second one. So I'm excited for when these new ones come out for my age group.
What about the kids 6 months and up to age 5? What's been the rate of acceptance among those parents?
That number I don't have off the top of my head. I think in Michigan, I'm pretty sure it's single-digit percentages right now that are vaccinated. It's very, very low. I know in the other pediatric age groups, it's 30%, which is obviously much lower than we like to see. Overall adult, it depends on age group. So as you get into higher age group, the percentage of people that have been vaccinated get much higher, right? The over 80 age group, it's 90% of people are vaccinated, right? And so it kind of trails off if you go every 10 year, every decile. But yeah, it's pretty new. I mean, it was May when that change happened. So it's and then it was June by the time offices really operationally had access to the vaccine and were able to give it and document all those things. So it's only been about a month, maybe 6 weeks since we've had the ability to do that. Yeah, the uptake's been low. It's been pretty low so far.
But no reason not to get it.
No, there really isn't. The risk. This is all everything in medicine is risk versus benefit, right? And we have so much experience now giving these vaccines to people and to kids. There's hundreds of thousands of doses have been given in our system. And what's nice about that is when there is an adverse event, right, when somebody has a reaction or something, we see that information, right, and we report that to the CDC. There's a panel of physicians that reviewed those cases to look at and see, is there something we need to be concerned about here? And so they've been very safe. They've been very good, very well tolerated. And so, risk benefit. There's so much COVID now that's circulating, especially if you have children. It is really a matter of time before kids are going to get it. If they're in daycare, they're in school. I mean, they're all going to be exposed. They're all going to get it. So, I would want my child to have some level of protection, knowing that it's an eventuality that they're going to get it. Because the outcome, there's always, whenever there's some issue cited with the vaccine, the risk of that issue with COVID is always higher. It's always higher, right? It's any adverse consequence from a vaccine, the risk of that as for consequence from the infection is always worse.
Pandemic's still here. The message stays the same. Appreciate your time. Thanks for coming in.
Yeah, thank you for having me.
From Henry Ford Jackson Hospital, Dr. Courtland Keteyian.